What does the health systems research teach us? Let's examine some of the evidence-based medicine for these. For those that are either taking internal medicine boards, geriatric boards, or renewing their board certification, it's best to know what these following studies have accomplished, because they are likely to show up as a board review question. In the left-hand column, we see models of care, and we've indicated what the goals of intervention are, what the key elements of the intervention might be, and then the actual outcomes. This first one is a care transition intervention, which was trying to decrease rehospitalization rates. Fundamentally, they assigned a transition code, did a home visit, and they included follow-up calls. A lot of these projects had follow-up calls, and they found that there was a slight reduction in 180-day rehospitalization. There wasn't so much of an impact on the 30-day rehospitalization, which of course is the time zone with which hospitals get penalized currently, but it does hold promise for that more extended reduction in hospitalization rates. Project Red, the re-engineered discharge. We also looked at decreased hospitalizations. After the first hospitalization, they had a ramped-up discharge plan, better education, a formal medication reconciliation process by the pharmacist, contacted the primary care provider, and had a follow-up call that also had a 30-day reduction in acute care use, as reflected by lower emergency room and rehospitalization. Notice the transitional care model. Looking at rehospitalization, they incorporated comprehensive geriatric assessment, or CGA. The post-discharge was similar to the other interventions, which included a transition coach with education. They had good results showing both decreases in 30 and 90-day rehospitalizations, and of course, those are associated with decreased costs. With guided care, you might see this as a fairly well-regarded study. Its overall plan was to reduce acute care on pre-discharge for the hospitalized patient. They also included medication reconciliation, some formalized patient education, and upon discharge, they had a primary care communication follow-up. They included a hotline, which was probably not the biggest impact that this intervention had, but they importantly had a home visit. Their results also showed that there's less acute care, although it was a modest effect. The program, called Interact, looked at rehospitalization rates, and it was focused on nursing home patients. In this case, you can see that the key interventions were the use of clinical care pathways, as well as making sure that the advanced care planning was done. They also found that for nursing home patients, they were able to put a dent in the 30-day rehospitalization rate. The DEEP program is focused on emergency room services and recidivism. The pre-discharge comprehensive geriatric assessment was applied here. There was enhanced PCP, or primary care communication, and there was a more extensive use of community services. They found that there was a short-term rehospitalization reduction. There was a reduction in use of the emergency room, and importantly, better physical and cognitive functionality. This JDWISE program looked at recidivism and was a nurse evaluation and enhancement of care through community resources. Here they found that there also was a reduction in rehospitalization rates. With the GRACE program, another important milestone program, the idea was to look at frail socioeconomically under-resourced individuals. The program was to reduce acute care use as well as nursing home usage. They found that there was home-based care by a team of nurse practitioners and social workers. They included the primary care provider, as well as the geriatric team in a co-management model format. They had specific care protocols for the nurse practitioner and social worker that were doing the home visit. They found that this program primarily improved patient satisfaction and made a small dent in the 30-day rehospitalization. It decreased nursing and home admissions. In terms of an accountable care organization format, this might be a good program to implement. With the bridge model, rehospitalization reduction was the goal of intervention. They used a more social worker-based assessment and follow-up for hospitalization. there was a modest impact on the reduction of rehospitalization. Age-friendly interventions was a newer entity within the healthcare system. This is sponsored by the Institute for Healthcare Improvement and the Hartford Foundation. The bottom line is that you apply the geriatric 4Ms at each patient encounter. The 4Ms are the what matters: medication, mobility, and mentation. Rush Medical Center discovered that they were able to reduce hospital length of stay by 7/10 of 1 day, which is nearly 1 full day. The hospital administration is just all smiles about this. It's tremendous cost savings for this, and it reduces acute care utilization here in North Dakota at Sanford Fargo Our Clinic, which is a geriatric-forward patient-centered medical home with a monthly audit found. They have reduced hospital recidivism from 9% to 3%, which is pretty significant. In summary, with the geriatric models of care, we know that the acute care for elderly units are effective. They provide good quality transitions because they are a geriatrician-based inpatient unit with an interdisciplinary team, or the team-based care. Anything that incorporated comprehensive geriatric assessment or team-based care was superior to individual nurse or teams of nurses and social workers alone. It's important to remember that you do need geriatric expertise to optimize the transition for these frail older adults. All of these programs targeted frail older adults, but didn't necessarily address all older adults. There's different levels of functionality. If you target somebody that has frequent hospitalizations or somebody that has deficits in activities of daily living prior to coming into the hospital, those are the patients that are most likely to benefit from the geriatric intervention. That leads to the third point, which either geriatric co-management or comprehensive geriatric assessment are strong adjuvants for enhancing transitions of care, whereas inclusion of home visits enhanced education. Transition coaches and hotlines all had very modest effects, but overall they were favorable. We know that the federal government has an invested interest in Medicare to try to improve transitions of care because of all the costs. Medicare introduced transitional care management payment codes, but there are penalties that are accrued if you have a rehospitalization rate that's above the regional average in your particular Medicare catchment. Some of the things that we can summarize in terms of best transitional care practices are to identify factors that make the transition more complex. Those include things like whether you know if the patient has some form of cognitive impairment or not. Based on a national survey, 80% of primary care doctors have no idea that their patient has some form of cognitive impairment. If you don't ask, you won't know. It's important to engage community health workers, particularly in communicating. For example, having a physician communicate with the home care agency. That could either come from the primary care provider or the hospitalist. It's also important to build contingency plans. We'll give you a trial at this venue. If that doesn't work out, then we need to consider this venue. Also, consider rehospitalization risk indices. Somebody's going to be a recidivist if they have high age, high medical complexity, and a history of rehospitalization and has dementia. Finally, better use of palliative care, if not hospice care. With addressing what matters, one hospital study found that just by implementing advanced care consultation services, they were able to reduce future intensive care unit admissions by over 80%, so that was pretty impactful. With the skilled nursing facility black hole, the primary care provider will not know the patient who is admitted. It's a newbie for that provider with a lot of catch-up. If the patient's discharged with subacute delirium, it's even worse because you can't get information or good history from the newly admitted resident. The primary care provider could lack information on the care received from the hospital, so there may not be a rapid turnaround on the discharge note. If the nursing home doctor does not have access to the electronic medical record, although that's starting to be solved with the shared electronic medical record platforms, the other problem is that there's no medication reconciliation. The medications that were listed in the outpatient record may not be the same ones that are listed in the hospital. They're really not the same as they are in the nursing home list. Dealing with medication reconciliation is quite the job. Once the patient leaves the nursing home, those gains in rehab are quickly lost at home because they're not doing their rehab therapy, which is another issue. There's different models of care in terms of the discharge venues. The most beneficial of all the options are the home-based care. As a provider, you need to certify that the patient has a homebound status and that they have a skilled nursing need, whether that be nursing, including diabetic teaching, physical therapy, and speech therapy. They will also have potential options for occupational therapy, social work, and home health aides, which are key. As you can see in the photograph, you might have a home health aide assisting an individual with transfer from the washroom. The discharge venues include skilled nursing facilities. You have to certify if the individual has Medicare. Not everybody has Medicare Part A, but if they do, Medicare Part A allows for 100 days of skilled nursing care. If you've been in the hospital for 3 consecutive nights and you have a skilled nursing need, such as intravenous therapy nutrition, artificial nutrition, complex wound care, ostomy care, or extensive rehabilitation, the problem now is that you get 20 days totally covered by Medicare. On the 21st day, it starts a copay. There are a lot of older adults who aren't progressing as rapidly as you would hope by that 20th day, but then they all of a sudden get these pressures to copay. The copay may not be all that crazy. It's a 20% copay. There are a lot of people who don't have a lot of savings, and they really can't afford that continuation of the nursing home. They end up getting prematurely discharged from the nursing home, and these are the people that end up bouncing back to the hospital.